morning and a very warm welcome to everyone joining us today for the Breakfast at Yam Health, the webinar series. I'm Dr. Mariana Nabila, Medical Officer from Department of Surgery. So today's session is titled Beyond Mechanical onto Hormonal, Redefining Surgery for Obesity. So as we all know, obesity is no longer just a lifestyle issue or a cosmetic concern. It is a complex chronic disease with profound metabolic, societal, and economic implications. Lifestyle and medical therapies often fall short in patients with established metabolic disease, and bariatric surgery actually remains the most effective long-term treatment. But for many years, bariatric surgery has been viewed as purely mechanical solution, making the stomach smaller or bypassing the intestine. However, this doesn't really explain and accounts for the profound and rapid metabolic changes we see immediately after surgery. So today's talk will look beyond the mechanical concept of weight loss surgery and explore the hormonal and metabolic mechanisms that truly redefine how we manage obesity. So it is my pleasure to introduce our speaker for today, Dr. Wong Wei Jin, Consultant General and Upper GI Surgeon from the Department of Surgery. So Dr. Wong has extensive experience in metabolic and bariatric surgery. He completed his upper GI sub-training at Hospital Sultanah Aminah Johor Bahru and the National Cancer Institute Putrajaya. He pursued his fellowship at China Medical University Hospital, Taiwan, under the mentorship of Prof. Wang, a renowned surgeon and pioneer in the field. So without further ado, I would like to invite Dr. Wong to begin his presentation.
Okay, a very good morning to everyone. Very sorry for the slight technical difficulties. My name is Dr. Wong. I am one of the senior lecturers at the Department of Surgery, currently working in the Upper GI Surgical Unit. So just a bit of background for me, I've just recently completed my training in subspecialty training, and I have just came back to UM for about a year or so. So when asked to do this breakfast talk, I thought I wanted to highlight the issue of bariatric surgery. As some people might know, it has gained quite a lot of attention recently. Not all of it is good attention. And I wanted to hopefully dispel some of the myths that surround bariatric surgery. So the topic I chose was this: beyond mechanical onto hormonal, redefining surgery for obesity, so that hopefully by the end of the 20 minutes or so, we can have a slightly better understanding of the role of bariatric surgery, especially in the Malaysian context, which I feel is very, very relevant these days. The first thing I want to get out of the way is this understanding, which is very important, that weight loss surgery, which is the process of turning someone who looks like this into someone who looks like this, is not the same as cosmetic surgery. Yeah, it is not cosmetic surgery at all. It is in fact metabolic and bariatric surgery. And there's a very specific reason why we have chosen to use this term and to shy away from the term cosmetic surgery. So very quickly, I'll go through a brief history of bariatric surgery, the obesity epidemic, how does metabolic surgery work, what are the current guidelines, and finally some conclusions. So this gentleman, going straight into it, this gentleman, he is a king from the 10th century of Spain, and he was the king of Leon in Spain at that time, and he was known as King of Leon de Sancho. He's quite a big guy, and he actually lost his throne. So back in the day, when the kings of Europe had to lead their armies into battle, so he lost his throne as the king of Leon, because he could no longer ride his horse and he could no longer pick up a sword because he was too big. So in an effort to treat this, the court physician at that time sewed his mouth shut so that he could only have fluids through a straw. And after that, because he could only drink water, he lost a significant amount of weight and he managed to regain his throne after losing weight. And we consider this the first bariatric procedure in history. Whether or not how accurate or not, we're not sure, but there is some myth around it. So we kind of attribute this to be the first bariatric procedure in history. So bariatric surgery is broken down to a few words. The word BAR, it means weight. It's an old Latin term. ARTI means treatment. And finally, ic means pertaining to. So bariatric basically means treatment of weight. So bariatric surgery means surgical treatment of weight. That is the definition of what it is. And I think it is especially important in Malaysia because of this epidemic that we are facing, this obesity epidemic. And if we ask ourselves properly, we don't actually we are so used to seeing people who are big that we actually don't recognize it anymore. But the statistics are quite frightening. So as you can see, this was published back in 2011 in one of our local newspapers. And in Southeast Asia, the Malaysians ranked the largest, right? 44.2% of our population in 2011 had a BMI of more than 25 kilograms per meter squared. And then moving on to the New Straits Times, and this was in 2016. So 5 years on, we became the fattest country in Asia, and we maintained this up to 2021. So this was in the Star, taken from 2021. Uh, from the fattest country in Southeast Asia, we are now the fattest country in Asia, the whole of Asia. We are the largest in terms of BMI. And we know that with the obesity epidemic comes all these things, right? Uh, the combination of diabetes, high blood pressure, and heart disease, the term metabolic syndrome, and this was back in 2019. And so in 2021, where about 44% of our population is obese, and this was published in the recent NHMS. Now in 2023, as you can see here, 54.4% of our population is overweight or obese with a BMI more than 25. So basically, 1 in 2 of our population is overweight or obese. And this is a problem because, as I mentioned just now, metabolic syndrome, diabetes, high blood pressure, dyslipidemia, heart disease, which obviously has a very high healthcare burden on us. And more than that is, of course, 8.5 million, sorry. So about of the 54.4% of our population, 35.9 or 8.5 million of them have metabolic syndrome. And this was taken from our NHMS survey back in 2023. So more than the issues of metabolic syndrome is the association with being overweight and cancer. So as you can see from this chart, the incidence or the likelihood of you developing adenocarcinoma of the esophagus is 3.3 times higher if your BMI is more than 25. Endometrial cancer, 4.7 times the chance of developing. Breast cancer, 2 times as many. Stomach cancer, 1.82. Pancreatic cancer, 1.47. And colon cancer, 1.5 times that of the normal population. So not only do obese people have a high likelihood of metabolic syndrome, they also have a high likelihood of cancer because of the low level chronic inflammatory state that obesity induces. And of course, with cancer, the treatment becomes very difficult when they are obese because surgery becomes more challenging. The dosages of chemotherapy also become very, very difficult to calculate when someone's body surface area is so large. On top of that, there's OSA, so obstructive sleep apnea. As you can see, taken from the American Diabetes Association, if the BMI is less than 25, then the likelihood of you developing OSA is about 2 to 5. But once the BMI is more than 40, there's almost a 100% chance that you will develop OSA. And the relative risk for OSA, as long as you're obese, is 10 times that of the normal population. So the combination of metabolic syndrome, the likelihood of neoplasia, and OSA in Malaysia has and will continue to cost us millions because we're treating all the side effects of obesity. Yeah, we're treating diabetes, which is caused by obesity. We're treating cancer, which is caused by obesity. We're treating OSA, which is caused by obesity. So my point of view is, why don't we treat the source of all this rather than treating the consequence of obesity? We should treat the source, which is the obesity, as opposed to just treating the diabetes, the cancer, and the OSA. So what's the solution then? Yeah, we know what the problem is. As mentioned, 54.4% of our population is obese. 8.5 million Malaysians have metabolic syndrome. The likelihood of cancer can be up to 4 times higher than that of normal. The likelihood of OSA is 10 times that of normal. So of course we can tell our patients, you have to follow a healthy lifestyle, right? Exercise, eat well, don't eat this, don't drink this. But realistically speaking, significant drastic healthcare changes, lifestyle changes, literature has shown us will only lead to about 5 to 10% excess weight loss, which is not enough for these people. And on the market now, thankfully, we have medications. So we have all the GLP-1 RAs, which is the new kid on the block. We have things like Contrave, which are neuromodulators. And the use of medications in combination with lifestyle modification has been shown to result in about 10 to 15% excess weight loss. So quite good, but again, still maybe not enough. So what about surgery? What about surgery? Surgery so far has come with, as mentioned, a lot of stigma. And this stigma has been, of course, well earned because in the past, bariatric surgery or weight loss surgery was started in the 1950s with an open jejunal bypass. And this was only done in very, very obese individuals, BMI more than 50. And this technique was then changed to the open gastric bypass. And as you can imagine, open surgery for individuals of this size was very, very morbid. They resulted in very long ICU stays, a lot of wound complications, and a lot of complications from the surgery itself. So it wasn't very well adopted until 1994, or about 30 years ago, when the first laparoscopic gastric bypass was performed. And with the advent of the laparoscopic era, we found that the morbidity had dropped significantly. So from something that used to be very, very morbid to a very low complication, very low morbidity rate. And since then, it has kind of exploded into many, many procedures that we can do. So as you can see from this slide, there are actually many, many procedures that can be chosen for bariatric surgery. It is up to the treating physician as well as the patient which one they choose. But basically, because of the laparoscopic era, there's so much more we can do. And the uptake of bariatric surgery has really increased in the past few years. So much so that in 2023, almost 600,000 procedures were done worldwide. And in Malaysia, in 2023, about 3,000 procedures were done. About 400 in 2016. So from 2016 to 2023, over the period of about 7 years, we've gone from 400 procedures a year countrywide to about 3,000. So so it seems to work, but how does it work? Um, these are the two most common procedures, right? The RYGB and the sleeve. And we used to think of it in terms of malabsorption and restriction because we make the bowel shorter, we make the stomach smaller. So we thought it was purely mechanical. And this really is the topic of the point of my lecture today, that we used to think that it's a purely mechanical procedure. When if you shorten the gut, of course you will absorb less, or if you decrease the size of the stomach, then of course you will eat less. So this is what we call the traditional mechanical concept. However, we realize that it does not explain the changes that the patient will experience in terms of hunger and satiety. Because technically, if you make the stomach smaller, and if there are no changes to hunger, you should still feel as hungry, right? You should still feel as hungry, only that you're able to eat less. However, we find that patients who had the sleeve done, they don't even feel hungry. So there's something that has been driving the hunger that has now been reduced after the sleeve. Also, if we shorten the gut or if we do a sleeve, then technically, again, as mentioned, you should still feel hungry, just be able to eat less, but you should still have the same amount of satiety, meaning that after eating, which is the break, so hunger is the driver and satiety is the break. So after eating, you should still feel hungry again quite fast. Yeah, for individuals who are obese, they have issues with satiety. After they eat, they are not sated for a very long time, then they eat again. But after surgery, we find that they remain sated for a very, very long time. So a traditional mechanical concept does not explain these changes in hunger satiety. So much research has been done over the years, and we realize now that actually it starts up here in the brain. And we realize that there's actually three main factors, and we divide hunger now into what we refer to as homeostatic hunger and hedonistic hunger. So homeostatic hunger is the hunger that keeps us alive. We know that we need to eat to live. And if we don't eat, then eventually we will die. So homeostatic hunger is the hunger that keeps our body at homeostasis. But hedonistic hunger is the hunger that we feel one day when we feel like, too stressed out, so we have something sweet. Or you're driving down the highway back home, and then you feel, you're not so hungry, but then you see an advertisement for like fried chicken, then you feel, oh, I feel like having fried chicken. Or for us who operate, we're in the OT, and we're not really hungry also, but someone has put some snacks there, and then we eat it anyway. So that's hedonistic hunger. It doesn't keep us alive. It's the hunger for pleasure. And along with hunger is what we call abnormal satiety. The fact that some individuals don't feel sated for very long. After a meal, we're supposed to feel sated for about 4 hours, but some individuals within 2 hours, they already feel hungry again. So there's something wrong with the satiety. So these are the three main issues, and we've realized that it starts here in the stomach with the hormone known as ghrelin, and over here in the gut with three hormones known as GLP-1, PYY, and dopamine. And after a lot of research, we found that when we reduce the size of the stomach, or when we do a bypass and increase the velocity of delivery of food to the hindgut, we actually are able to reduce the amount of ghrelin, which is the hunger hormone, the hormone that makes you hungry, and we're able to increase the levels of GLP-1 and PYY, which are the hormones which induce satiety, while reducing dopamine. And this all feeds back to the brain. So this is what we refer to as the hormonal concept of bariatric surgery, reducing the amount of ghrelin, therefore reducing the hunger, and increasing the amount of GLP-1 and PYY, therefore inducing satiety for longer periods, feeding back to the brain, eliminating hedonistic hunger and abnormal satiety, and leading to the term the enteroendocrine encephalic axis and the new term of metabolic surgery. So we've moved away from the understanding that it's purely mechanical and on to the understanding that actually it's metabolic. There is significant changes in hormones, there is significant changes in metabolism, which all feed back to the brain in this axis and affect how an individual processes and thinks about food. To summarize it, there's one theory known as the foregut theory, which tells us that if we bypass the foregut, which is basically the duodenum, we reduce the amount of ghrelin, reduce the amount of gut dopamine, and we reduce certain diabetogenic factors which as yet are unrecognized. So we don't really know which factors, what these factors are yet, but we found that when we bypass the foregut, individuals produce less diabetogenic hormones. And on the other side, the hindgut theory. So by increasing the velocity of hindgut delivery, we can then increase the amount of GLP-1 and PYY. We bypass the foregut and we shorten the hindgut, and that is the axis of the current understanding of metabolic surgery. So the big question is, sure, all this theory sounds good, but does it work or not? We want to see whether the theory equates to the real-world data, and thankfully there's a plethora of data out there. So the Sleeve Pass trial, the SM-BOSS trial, the Stampede trial, many trials which tell us that bariatric surgery really works. And in a very nice meta-analysis published in JAMA in 2016 of 7,000 American patients, where they compared surgery versus best medical therapy, they found that, as you can see, the blue dotted line are the non-surgical matches, so those who did not have surgery, and the dark line is those who did have surgery. And you can see that after 10 years, those who did not have surgery versus those who did have surgery, surgery remains the best weight loss option. And across the pond in England, published in BMJ in 2013, a meta-analysis of 11 studies at 796 patients, they had the same conclusions where basically all sorts of all parameters that were measured, weight loss as well as HbA1c, were strongly favoring bariatric surgery. So I propose that the solution, as mentioned, bariatric surgery remains the most robust weight loss treatment control, which lasts for more than 10 years, as opposed to just depending on someone's lifestyle changes. So this has led to an evolution of guidelines for bariatric surgery. So the NIH, which is the American National Institute of Health, for a long time has been the kind of like the mainstay of guidelines for bariatric surgery. Back in 91, this was the recommendations back in 91, where surgery was mostly open. It was reserved for individuals with very high BMIs, and there was no standard reporting. And this was changed in 2004 when it was revised. And what was found was that most of the procedures had now become laparoscopic. Treatment should be tailored to the patient, and there were suggestions to reduce the threshold for BMI for surgery. And then in 2022, which is more recent, these suggestions to reduce the BMI threshold. So initially it was BMI 40, but then in 2022 it was reduced to BMI 35 with comorbidities, and BMI 30 with comorbidities, and surgery was found at this point to be entirely laparoscopic. But what was interesting about 2022 was that there was a suggestion that BMI should not be the only marker for surgery, and it should be adjusted for ethnicity. There was also no age limit now. So back in 2004, the age limit was set at 65. But moving on, then it was the new guidelines in 2022 shows us that actually there's no age limit. So the oldest patient done worldwide was about 82 years old, who had bariatric surgery done. Okay, so this is a summary from the 2022 guidelines, as I mentioned. So 2022 was really the first time the ASMBS, the American Society, as well as IFSO, which is the International Federation, came together and agreed upon a set of guidelines for bariatric surgery. And I wish to highlight this because it is quite different from what it used to be. So this was the criteria for surgery. The limitations of BMI were well understood, but essentially what they suggested was if an individual's BMI was more than 35 with comorbidities, then they could be recommended for surgery. 32.5 actually. And then, so they should mention that it's suitable for individuals with class 1 obesity. And if there are no comorbidities, then 35 would probably be a good cutoff. But as mentioned, the cutoffs for surgery should be adjusted for ethnicity. Excuse me. And it was suggested that class 1 obesity for an Asian population, so ours, should be 27.5, and class 2 obesity should be 32.5. So essentially, ASMBS, if so, has agreed that if you are Asian with diabetes and a BMI more than 27.5, you should be considered for some form of metabolic surgery already. And if your BMI is more than 32.5 and you're Asian, then it does not matter whether you have comorbidities or not. You actually can be considered for surgery. And the reason why these recommendations were made, it was because it was found that Asians had a lower, developed metabolic syndrome at lower BMIs compared to our Caucasian counterparts. So I understand that this can be quite controversial. And some people have asked me, well, then am I going to operate on someone with BMI 28 with metabolic syndrome? And my answer to that is very simple. I don't think I will get those patients because at our institution, the average BMI, as you can see later, is going to be very high, and I don't think I will ever run out of the patients with BMI 40, 50 who really require surgery. And maybe those who are smaller can consider some of the newer agents like the medications. So to conclude very quickly, the obesity epidemic, which is really troubling our nation right now, as mentioned, 8.5 million Malaysians with metabolic syndrome, 54.4%. Right? So our population about 33 million. So about 16 million who are overweight. In combination with the scientific literature and the real world data, has told us that there's actually a very urgent need to intervene in Malaysia, not just because of the healthcare costs, but because of the fact that our population will become very unhealthy. So what have we been doing so far? As mentioned, I've been back in UM for about a year since I completed my fellowship. And I just want to highlight a few cases of ours. So this is Mr. H. As you can see, he's wearing the UM scrubs in preparation for surgery. And in June of this year, he was 188 kilos. His HbA1c was 6.1 despite medications. And he had a BMI of 64.7. So this was him 3 days post-op with the team. That's my team. And this is him now. So 5 months post-op, he's now 132 kilos. He's lost 50 kilos plus. His HbA1c is now 5.3%, and he's off his medications, and his BMI is 44. And we do anticipate that he will lose further weight, and hopefully he'll drop down to below 100 kilos. But more importantly, as you can see, he's no longer requiring a cane to move when he needed a cane to move in previously. And also importantly, he is no longer requiring his OHAs. Another case, this is a lady who did not want to be recognized. So as you can see, but she's wearing the UM scrubs. So she came into me with a BMI of 68.1. She was 189 kilos with an A1C of 7.5 on metformin. She also had AHI. Her AHI score was 90.3. So she had OSA, sorry. And she was amlodipine and Exforge. So she had the classical triad of metabolic syndrome with OSA, requiring medications, and a very high BMI. So that was in July, which I operated on her. This is her post-op day 3 going home. She was happy. And this is her now. So maybe the picture doesn't really do it justice, but 5 months post-op, she has lost more than 40 kilos, right, from 100 to 145 kilos. Her HbA1c most recently, just taken just last week, was 5.5, and she's off her medications now, so no longer require metformin. Her BMI is now 52, so she's come down significantly from 68. She still has a long way to go, undoubtedly, but we do anticipate that she will drop further. Her AHI now is 1.3. So from 90.3, it is now 1.3. And we managed to stop her Exforge and reduce her dose of amlodipine. And as she loses more weight, we do anticipate that she will be able to stop her amlodipine in the future. So at UM, I think the most important thing is that the MDT, the patient selection has to be very strict. And I'm very grateful for the support of GA, our anesthetic team, our ICU team, the OMFS team, psychiatry, neurology, and respirology, who all come together Of course, also mentioning endocrinology and gastroenterology, who all come together in quite a large MDT to ensure that the best care is delivered to these patients. And just to look at the audit for the past year or so at UM, I've operated on 43 patients. As you can see, the male to female ratio, there's a very large preponderance of females, 31 compared to 9. Majority of our patients are Malay, then Chinese and Indian, which kind of follows the national demographic anyway. But here's what I want to highlight. The average age is 44, the youngest being 19 and the oldest at 67. The average BMI operate on is 41.43, with the smallest being 33 and the largest being 68, which is the lady you saw just now. Most of them, in fact, almost all of them have diabetes with an average HbA1c of 6.46, the lowest being 5. So some patients were not diabetic, but the highest being 12. And OSA. So mean AHI is 37.1, the lowest 3.1, and the highest AHI operated on was 90.3. The length of stay post-op is about 2.5 days. And thankfully, the complication rate has been quite acceptable at 2.3%. So to conclude, the obesity epidemic is a significant health and resource draining issue. 8.5 million Malaysians are overweight with metabolic syndrome. Obese individuals have a 10 times increased risk of developing OSA. And MBS, metabolic and bariatric surgery, provides the most robust weight loss option, as I've shown you from the available literature, as well as what we've been experiencing in UM. The understanding of it has shifted towards a traditional mechanical concept to the understanding that it is metabolic surgery, right? A hormonal concept, which emphasizes foregut exclusion and enhanced hindgut delivery, affecting the hormones which I mentioned just now, ghrelin, PYY, and GLP-1. Bariatric surgery can be considered in those with BMI more than 27.5 with comorbidities. However, I think in our institution, we still have to be careful and have to focus on those who are very, very large and get through those patients first. It does require significant MDT effort to ensure best outcomes. So that's my presentation for today. Thank you so much for your attention. This is my email, and this is the gentleman which I trained under, Professor Huang in Taiwan, in Taichung, who has given me quite a lot in terms of my understanding, and I'm very grateful to him. Thank you so much.
All right, so thank you very much, Dr. Wong, for the very comprehensive presentation that truly redefines how we understand the obesity treatment. I'm just going to open the floor for any questions. All right, so far, we have one question here. Is by Sarah Ahmad. Is there an obesity clinic in PPUM that we can refer our patients to? And congratulations and good work to yourself, Dr. Wong.
Oh, thank you for a nice comment. So there's actually two pathways now, and we are in the process of streamlining the pathways. So basically, the one pathway is there's a combined clinic with endocrinology, gastro, sports medicine dietitian that is every first and third Wednesday in the endocrinology clinic. So most of the patients who get sent there are those who are, I mean, of course, they're obese, they have some form of metabolic syndrome, but they're not yet fully ready for surgery because, psychologically, they may not be ready for surgery. So they go there first and they undergo some treatment, and they undergo counseling. There's a dietitian there as well. And if they do not want surgery, they remain at the clinic. But if they want surgery, then I see them there every third Wednesday of the month. The other pathway is some departments have been referring directly to me. So individuals who already know they want surgery, because these days with social media and all this kind of thing, a lot of people come to our hospital already asking for surgery. So if they're already convinced that they want surgery, so they're past the pre-contemplation phase, they're in the ready phase for surgery, they get sent directly to my clinic. So my clinic's every Thursday morning, basically. Yeah. So they come with a letter and then I can see them there and start the counseling.
Okay, Dr. Wong, just another question. Based on your current experience in the MMC, what are the biggest challenges in actually implementing the metabolic surgery locally?
I think the biggest challenge is having an organized MDT. So when I first came back, because I suspect, I'm not 100% sure, but I suspect that because we're so used to seeing individuals who are large, we actually don't think it's a problem anymore. So there was some barriers in terms of getting people on board to help treat these individuals. But after demonstrating the data, after showing people what it was like, and of course, after the success of a few cases, then the MDT grew, and it was, I guess, the biggest challenge was convincing people that it works lah. So, thankfully, that has been shown, and the outcomes, I think, speak for themselves. I would say that getting the MDT together was probably the biggest challenge lah, but that has been overcome, and now we have quite a united group that is happy to treat these patients. Yeah.
Okay. I think one last question is asking about the cost of the actual surgery in the MMC and the total cost of treatment in the MMC.
Okay, so surgery itself, surgery plus all the equipment will cost the individual about 10,000, about 10K all in. That is not including, of course, the clinic visits pre and post, and of course, if they're on medications, so if, for example, they're on Saxenda or Ozempic, that kind of thing, then that will be a bit higher. But surgery itself, for the 2 to 3 days they stay in the ward, is about 10,000.
Okay. I think there's no more other questions so far. Thank you so much for your time. I think we can conclude our sessions for today and continue with the next talk.
Thank you so much.